Okay, welcome. Thank you for joining us this evening for our program. Tonight, Dr. Stephen Rauch will present a fascinating discussion of how hearing works, how and why it fails, and what we can do about it. My name is Helen Liu, and I'm the Programming and Partnerships Manager at Carey Library. Before we begin, I want to take a moment to thank the Carey Library Foundation. Their support enables us to bring programs like today's event to you. Now I'd like to introduce our speaker. Dr. Stephen Rauch is Professor and Vice Chair of Clinical Research of the Otolaryngology Department at Harvard Medical School. He is the Vestibular Division Chief at Massachusetts Eye and Ear Infirmary and a member of Otology Division of Massachusetts General Hospital. Dr. Rauch provides medical care to patients with hearing and balance disorders. His research and speaking are focused primarily on combined disorders of hearing and balance, including Meniere's disease, autoimmune inner ear disease, sudden deafness, acoustic trauma, and migraine. He consults with the biotech and pharmaceutical firms designing clinical trials for inner ear drug development and delivery. Dr. Rauch is also a professor in the liberal arts department at Berklee College of Music, where he teaches an undergraduate course on health and wellness. Welcome, Dr. Rauch.
Thanks very much. Thank you all for coming out. Thanks to the Carey Library for giving me a microphone to talk about this. What I'm going to do tonight is take a little while to talk about these things, about how hearing works, how we measure it, how we lose it, what those symptoms are, and then what we can do about it. And I'll try to put this all in a span of time that we'll have plenty of time for questions at the end. I'm going to start with a short video, if it'll play. This is about 3 minutes long. It's from the National Institutes of Health Institute on Deafness and Communication Disorders, and it's just a little animation about how ears work. And we'll go into a little more detail, but I really like the way this starts. So let me see if I can make it happen.
Have you ever wondered how sounds make their way from the source all the way to your brain? Take a trumpet, for instance. When it's played, it makes sound waves in the air. The outer ear catches the waves, which then travel through a narrow passageway called the ear canal. The sound waves reach the eardrum, which is a membrane roughly half the size of a dime. They make the eardrum vibrate, which in turn vibrates 3 tiny bones called the malleus, incus, and stapes. These bones amplify or increase the sound vibrations and send them to the cochlea. The cochlea is shaped like a snail and is the size of a garden pea. It is filled with fluid, and the sound vibrations make this fluid ripple, which creates waves. Hair-like structures called stereocilia sit on top of hair cells and are grouped together as hair cell bundles inside the cochlea. The hair cells inside the cochlea ride these waves, and the hair bundles are moved. The hair bundle on top of the hair cell turns these movements into electrical signals. As the hair bundles are moved, ions rush into the top of the hair cells, causing the release of chemicals at the bottom of the hair cells. The chemicals bind to the auditory nerve cells and create an electrical signal, which travels along the auditory nerve to the brain. Different hair cells respond to different frequencies of sound. The hair cells at the base of the cochlea detect higher-pitched sounds, such as a piccolo or flute. The hair cells toward the top of the spiral detect progressively lower-pitched sounds, such as a trumpet or trombone. At the very top, or apex of the spiral, the hair cells detect the lowest pitched sounds, such as a tuba. The auditory nerve carries the electrical signal to the brain, which interprets the messages as sounds that we recognize and understand.
Okay. It's hard to improve upon the efficiency of that presentation. They really nailed it. I'm going to go back over it with a little detail in a few places, but that's really the takeaway. So here's a cartoon of an ear. The ear canal is about 1 inch long between the outside world and the eardrum. It's about the same diameter as a yellow pencil. It's a straight shot. When your doctor looks in there, it's easy to see. Sometimes there's a little curve to the canal, but it's pretty easy to see all the way to the drum. There are little hairs out near the opening of the ear canal, the outside end, and there are little glands in the skin that secrete earwax, and that's also right out near the opening, not down on the inside. The skin of the ear canal, as it grows, it migrates outward, so it's always pushing the earwax out. And generally, ears, and most people, are self-cleaning. If you're always putting in earplugs or earbuds or hearing aids or Q-tips, you're thwarting that mechanism a bit by plowing the stuff back in. And then some people, just because of the consistency of the wax, need the ear cleaned. The eardrum itself is about the size of your pinky fingernail, and behind the drum is the middle ear, which is air-filled. It's lined with the same kind of mucous membrane that lines your mouth or nose or sinuses, but it has air in it. The air comes up from that passage running down to the lower corner of the slide, the eustachian tube. The eustachian tube is also about 1 inch long, but it's only about 1 millimeter in diameter, the diameter of a pencil lead. And it sits closed, and every time you swallow, as you contract the muscles in the back of the throat, it tugs on the eustachian tube and it opens for just a moment, letting the air pressure in the room equalize so it matches the air pressure in the ear. And any of you who've been on a plane know that feeling of a bigger pressure change equalizing. You can feel the pressure difference. Ear is very sensitive to pressure mismatch. In green here is the inner ear, and the front part of the inner ear is the coiled up cochlea. That's the hearing organ. Everything behind that, there's a central area with loops on it. Those are balance organs. So all of that together, hearing and balance together, is the inner ear. And it's bone, but inside it's partitioned into chambers filled with fluid. The fluid comes in 2 different flavors with very specific chemical differences that enable the ear to work properly. The entire inner ear, all taken together, is tiny, about the size of a dime. And from the inner ear are nerve fibers going to the brain. So if we were to look at that cochlea, the coiled up cochlea, and cut it open, it really does look like a snail shell. And across each level of it is a horizontal partition. You could think about it a lot like a parking garage, where there's a deck, and when you drive into the parking garage, you sort of spiral up to the top of the garage, and if you keep driving, you spiral back down again. And that's kind of what happens to the energy that comes into the cochlea. The energy enters in this very bottom chamber. Can you see my little arrow on the screen there? The sound enters in the bottom and it spirals all the way up to the top. It passes through this small opening at the top, and the energy comes right back down again in the top chamber. Back that up, sorry. There we go. So the vibrations from the sound are moving the inner ear fluid, and the vibrations in the going up the bottom and down the top are not necessarily synchronized. They're sort of out of phase, and that difference in the movements causes the middle chamber, the scala media here with a little blue box, to shift and vibrate, wiggle, and it's those movements that stimulate the hearing hair cells. The hair cells are all sitting on that flat membrane that spirals up through the cochlea, and they're in this elaborate organ called the organ of Corti. It's very elaborate, fancy, particular, and fussy architecture. In order for the ear to work properly, all these different cell types that are drawn here in different colors have to be working. They have to be in exactly the right position. And any disruption of that, any damage or degeneration or failure of any of those cells will cause hearing loss. So there are lots of different reasons the ear might have a failure or a breakdown. What you can see clearly in this cartoon is that there are 3 rows of outer hair cells. They're the ones colored purple, and there's one row of inner hair cells, which are the ones here colored blue. And the inner and outer hair cells have slightly different functions in converting the vibrations of sound into electric signals. Here's a cartoon of a single hair cell with the stereocilia at the top and the nerve contacts or synapses at the bottom. And as you saw in the video, when sound vibration moves those fibers on top of the hair cell, it initiates chemical reactions. So at the bottom of the hair cell, little packets of neurotransmitter chemical are released to the nerve. The rate of vibration, the frequency of the vibration is exactly the same as the frequency at which the hair cell drops neurotransmitter. So any of you who are musicians, middle C is 256 hertz. 256 means 256 vibrations per second. And a hair cell will vibrate at 256 vibrations per second. It'll drop neurotransmitter at 256 vibrations per second. If you did it at 440 vibrations per second, it would be an A on the violin or piano and so forth. As you double the frequency, you go up by octaves. So these hair cells are releasing neurotransmitter really, really fast. And the louder the sound, the more violently the stereocilia flail back and forth. And the more they move, the more neurotransmitter they release with each vibration. So the frequency or pitch of the sound is encoded by the rate of chemical release, the loudness by the amount of chemical release. It's very clever. Mother Nature is very clever. Those signals travel up the auditory nerve to the hearing centers in the brain where we make sense of them. Really, the ear just collects the sound and it encodes those sounds by frequency and intensity. Everything else, whether you're listening to a violin or a trumpet, whether it's your mother on the phone or a telemarketer, whether you're hearing a train go by or a fire alarm, whether somebody's speaking French or some other language, all of that is in the brain after the sound arrives. The ear just collects the sound in great detail. Here's an electron microscope picture of looking down on that organ of Corti from above, and you can see the 3 rows of outer hair cells and the 1 row of inner hair cell. The architecture of those stereocilia is also very particular. All those fibers stand up at attention, one right next to the other, and actually it's hard to see in this picture, but the tallest one is in the middle, and they get progressively shorter. It looks like your 2nd grade class photo, where everybody stands and the teacher lines you all up by height. And if it's not like that, the ear doesn't work. If we look at what part of the cochlea is sensitive to what sound, as the video mentioned, high frequency, high pitches, high frequency sound is most important at the base of the cochlea, and low frequency sound all the way up at the apex. You can think of that, the sound is coming in at the base, so the sounds that make a short trip or the high frequency sounds, it's like the short strings on a harp, and the long trip is the bass notes, just like the longer strings on a harp. And so the cochlea sorts the sound by frequency, and if we unroll it, you can think about it like a piano keyboard, but with 15,000 keys instead of just 88. The ear has exquisite sensitivity to very small changes in frequency. If you go to have a hearing test, we measure 2 things on a hearing test. In a good comprehensive audiogram, the hearing test, we put the patient in a soundproof booth, and the audiologist who does the test puts headphones on. The headphone is set to play a sort of static hissing sound like radio static in one ear as masking while they test the other ear. And they vary the loudness of the sound until they can tell what is the very softest sound you could hear. And they do this at an assortment of different frequencies, from low pitch up to high pitch. And in this plot on the left side here, the pitch or frequency of the test tone is laid out across the top of the chart, and it's like a piano, from low pitch to high. And along the vertical axis is loudness, with very soft at the top, and as it goes down, it gets louder, louder, louder. And the audiologist makes a mark at the softest sound you could hear at each pitch over these 7 or 8 test frequencies. And normal hearing is in the gray area that you see up at the top of the chart, between 0 and 20 decibels of loudness. So in this picture, red is right by international agreement, and if you're looking at a black and white plot, O is the right ear and X usually is the left ear. Anyway, on this picture, the right ear in red is normal, 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 and about 3/4 of the way across the plot, it sags in the high frequencies. A little bit of high frequency hearing loss like grandma might have. The left ear is similar, but it's worse. All the threshold is worse. In other words, the sound has to be louder before the patient can raise their hand to acknowledge that they heard it. So this is a plot of hearing loudness. The other thing we test in a complete audiogram is hearing clarity. And you can think of loudness and clarity like the volume in the tuner on your radio. For the clarity test, we mask one ear, test the other, and we have recording, standardized digital recording of a voice, and the voice is saying words. You will say, and it gives a test word. The word is always a consonant envelope with a vowel in the middle. You will say hat. You will say bike. You will say cup. You will say, and it goes on and on. We have hundreds of these lists. And the words are delivered at a loudness that we know to be well above the patient's threshold. So we know that they can hear it. It's audible. And the question is whether it's intelligible. And so the patient repeats the word, the audiologist keeps score, and they write down what percent was correct. What was the correct, the percentage of words correct. And if you look at this little table right over here, we see the word recognition score. On the right side was 100%, but on the left side it was only 40%. So the right ear is really very good. The left ear is kind of a piece of junk. The threshold is halfway down the page and the clarity is terrible. So this person would have an easy time on the phone, easy time having a conversation, as long as it's coming into their good ear. There are lots and lots of different reasons you might lose hearing. Some of those reasons, we'll go down a list here in just a moment. Some of them we would expect to affect both ears equally, like age. Both your ears are about the same age. And actually, both your ears probably have very similar life experiences. But if you had a firecracker go off next to your head as a child, or a gunshot, or something else, you can have hearing asymmetry. Now, it's great for patients who have a hearing problem to come and get a comprehensive audiogram at Mass Eye and Ear or at ENT offices, wherever. But there are a couple of apps that you could put on your phone that enable you to do a pretty good audiogram with your phone. These are from two different companies. Mimi is produced by a consumer electronics company in Germany, and it uses one method of hearing testing to do threshold test. And UHear is put out by a hearing aid company, and it uses a different method, but both of them are quite accurate. And you have to have earbuds or earphones that you plug into your phone and put them on. You have to be in a quiet room to do the test, but you can get a pretty decent threshold measurement, a loudness measurement. They don't have a comprehensive way for a do-it-yourself clarity test. These are free apps. You can get them at the App Store. Now here's another version of that audiogram plot I already showed you, with frequency across the top from left to right, loudness down the side from soft at the top to loud at the bottom. And the plot is now populated with common everyday sounds. You can see a dripping faucet and rustling leaves, a ticking clock. I don't know if you can see the picture from there, somebody whispering sweet nothings in your ear, baby crying, a piano, lawnmower, jet plane, and so forth. And you can see that these sounds vary by loudness and by frequency all over the place. And in the middle of the plot is a pale purple, a lavender zone. We call that the speech banana. And it's where most voices, where human speech sounds sit. And in a normal conversation, if you're about a meter away having a comfortable conversation, the voice is hitting your eardrum at about 40 decibels louder than your threshold. So you can see a red line across the chart. That's the lower limit of normal. So, you know, on average, if normal hearing is around 10 dB, normal conversation would hit your ear at about 50 dB. That would seem comfortable. Softer than that, you might strain a little bit. Louder than that, you might back up. And if you can see the letters in the speech banana, what you see is the vowel sounds are generally lower frequency. Ah, o, u. Many of the consonants have low frequency energy, but some of them s, f, th, are very high pitch. And so with the sounds scattered around like that, depending on where your hearing loss sits, you may not just have all or none. You may clip pieces of sounds. So here's a bright orange line of somebody with normal hearing, and as you can see, anything below the line is audible. It's louder than the patient's threshold. So all those sounds are louder than this person's hearing. This person has lost some high frequency hearing, and all that stuff in the upper right corner is excluded by their hearing loss. The chirping bird, the sweet nothings, the ticking clock. And as the hearing gets worse and worse and worse, more and more of the world is excluded, including more and more language. There are lots of reasons you might lose hearing sensitivity or hearing clarity or both. Could be genetic. You could be born with a hearing loss, or you could be born with a genetic composition that leads to hearing loss later in life. Lots of medications are toxic to the ears. We call this ototoxicity, and that can damage hearing. Trauma, head injuries, concussions. Other illnesses can be associated with hearing loss, and that could be the illness itself. It could be the medicines they're treating it with, but being a patient with other diseases can lead to hearing loss as collateral damage. The two most common causes of acquired hearing loss are loud noise and age. Loud noise is modifiable, age not so much. I put this picture back up just to remind you that the ear has lots of parts, and the parts have parts. The hair cell has stereocilia, it's got a nucleus, it's got neurotransmitters, it's got synapses at the bottom. There are somewhere between 40 and 50 different types of cells in the inner ear, the inner and outer hair cells, but lots of others. They all have to be working normally. They all have to be connected to each other in the right way. They all have to be structurally in the cochlea where they're supposed to be. It's a fussy little place. And if anything is not working, the whole thing doesn't work. So we can do a hearing test and we can see when you raise your hand or see your word score, and we know your hearing is not great, but it doesn't really tell us if it's a hair cell or a this cell or a that cell or a combination or a chemical problem with the fluid or a ruptured membrane. We really struggle, medically speaking, to try to figure out what really is going wrong in there. You know, it's like if your car isn't running, the mechanic can pop the hood and jiggle the wires and put it on the computer and wiggle things around and try to figure out, well, there's a lot going on under the hood here, but we really can't open it up and fiddle with it yet. So what's it like to be hearing impaired? The most common early symptom of hearing impairment is difficulty discriminating voices in difficult listening situations. Ease of communication depends on one thing. It's called the signal to noise ratio. The signal is what you want to hear, the noise is everything else. Right now on the signal, there isn't any noise. Fan. If you have good ears, maybe you hear the fan, but really there's no competition. Big signal, no noise. Easy to hear me. If you go out to dinner in a noisy restaurant, your dinner date is the signal. The other 50 people in the room are the noise. And your dinner date is here and the noise is here. They're not separated at all. They're together. Sometimes the signal's louder. The noise is louder than the signal. And as the signal to noise ratio gets closer to 1 or less than 1, you struggle. And that's not just somebody with hearing impairment. That's everybody. All of us have that. Now, there's another kind of signal that we get too. It's not just how loud I'm speaking or how clearly I'm enunciating. You can see me speaking. And the last 3 years, we haven't been able to see people speaking. And they're all like this. And with hearing impairment, if all you see is the eyebrows, it does not give you a lot of information. So our hearing impaired family members or my hearing impaired patients have been miserable during this last few years. And in fact, they find that communicating by Zoom has been fabulous because on Zoom, nobody wears a mask. You just have the face. And it makes it much easier because you get the visual cues to supplement what you're hearing. Noisy environment where there's a lot of background noise, everybody struggles. People with hearing impairment struggle more. Sometimes it's not a lot of background noise, but it's just a room with bad acoustics. It reverberates and echoes. Doesn't have to be out in a restaurant. It could be everyday life, sitting around the dinner table, the clattering dishes, everybody talking at once is pretty nearly impossible for somebody with a lot of hearing loss. And any of you, perhaps with aged relatives, know that at the holidays, it's really hard to keep grandpa or grandma engaged in the conversation because they can't follow it. People with hearing loss often have tinnitus or tinnitus, ringing in the ear. It's a side effect of hearing loss. Nearly everybody with hearing loss has tinnitus. Lots of people with normal hearing have it, but everybody with hearing loss has it. Some people only notice it occasionally or it's faint. Other people have it as screaming intense noise that drives every other thought out of their head. How loud it seems really has very little to do with the severity of the hearing loss. We see patients with mild hearing loss who complain of screeching tinnitus, and we see other people with severe loss, and the tinnitus they don't notice it much. Tinnitus seems to track more with general health and wellness. When people are sick or tired or upset, stressed out, the tinnitus is much louder. When they're at Club Med on the beach, when they're fit and focused and busy doing something, they don't really notice it. So we think of tinnitus as an alarm system for your general health and well-being. If the alarm is ringing, if your smoke alarm is ringing, you don't take the batteries out. You go and look for the fire. If you're having tinnitus, you need to go look for the source of the stress or fatigue, your nutrition, your sleep, and so forth. And if you deal with those, the tinnitus tends to take care of itself. One of the common behaviors we see in people who have trouble hearing is that they get in a habit of doing all the talking. If they're with a group of people, they can't follow the conversation because of their hearing loss, so they start talking and they tell a story, and they tell another story, they hijack the conversation to Cuba. You know, it's like the only way they can feel like part of the party is if they're talking, because they get left behind otherwise. Some people with hearing loss are in denial. You know, I see couples that come in all the time and the guy is sitting in the examining chair and he says, I don't have a problem. I hear everything I want. And his wife is there. No. I might add that if you lose hearing gradually, you know what you're hearing. You don't know what you're missing. There's no way for you to know how much sound or how much conversation is happening around you because you just don't hear it. So it may seem to you like you're hearing a lot, but there may be a lot more besides that doesn't get through. People with hearing loss are isolated. You can be in a room full of people, but because you can't easily converse and communicate, you're cut off from them. If you've never done this, I'll suggest to you an experiment. If you go home this evening and turn on your TV, and you could put on your favorite, whatever you binge watch, your favorite sitcom or something, and close your eyes. You'll listen, or put on the evening news, whatever you want. Close your eyes, now all of a sudden you're blind, and you listen and you can follow the story perfectly. Then open up your eyes and turn off the sound. Now with the news, the commentator is looking right at the camera. You see their mouth. There's a text crawling across the bottom of the screen. There's some kind of infographic up behind them to reinforce the message. But if you put on a sitcom or a movie or, if you've ever been on an airplane flight and forgot your headphones, and so you're watching a movie across the aisle in somebody else's seat, you can see the movie, but you don't know anything, so you're trying to figure out what's going on. That's like the tiniest little hint of what people with hearing loss put up with all the time. So people are isolated, and as I mentioned, at a family get-together where grandma is there, the cousins, the grandchildren take turns going over and sitting and trying to have a conversation, and you repeat yourself and you repeat yourself, and she smiles and nods, but you don't really feel like you're connecting necessarily. It's exhausting for you, for the grandchild. It's equally exhausting for grandma. And after a while, the kid drifts away and another cousin comes over and takes a crack at it, trying to keep that aged family member in the loop. But it's effortful, it's exhausting, and it's especially exhausting for the person with the hearing loss. They have to concentrate, they have to work really hard. And after a while, they kind of check out. They don't bother. They just drift away from social activities. They can crank their TV up loud, perhaps, but to be with other people is just so much work. We now know that kind of isolation can also lead to accelerated cognitive impairment. Part of our brain health has to do with being engaged with other people and with other sensory stimuli, with vision and hearing and so forth. And as we age, vision is not so great, the hearing is not so great, mobility is not so great, it's harder to get out. And so people spend more time staying by themselves. They can't really read the way they once did. They can't watch the TV very well. They can't hear the conversations. And so they're just living inside their own head. And we see cognition decline. It's a big public health problem. It's one of the big pushes to get people to find out about their hearing and try to do something about it. And those of us who don't know better shout. And shouting doesn't necessarily make it easier for people to hear. Enunciating, speaking with hyper enunciation helps, but shouting generally doesn't. So what are we going to do about it? Actually, this is what we do about it. We make sounds louder with hearing aids. Hearing aids are amplifiers. It's really all they are. Doesn't matter what you read in advertising, pretty much they make sound louder. We are able to tune the bass and treble. You know what I'm talking about? So you can make the low frequencies a little louder than the highs or the other way around. So we can tune them a little bit. Either the user can do it themselves or the audiologist does it for you before you take it home. But basically they make stuff louder. Hearing aids come in lots of sizes and shapes. Down at the bottom here is a little teeny in the canal. It's about the size of a raisin. They really don't sound great. They cost a fortune because the companies are playing on your vanity. They're selling you something that nobody's going to see, and they give you they mark up the price a lot for that purpose, but they don't last as long and they don't sound as good and the batteries keep wearing out, and we don't really recommend those to anybody. As the hearing aids get a little bigger and a little bigger, they sound better, they last a little longer. But all of these ones that go right in the ear are a problem. The microphone and the speaker are so close together that they whistle and squeal a lot of the time. And many of the people using them are seniors who maybe don't have great vision, don't have manual dexterity. And for somebody with arthritis and poor vision, trying to find one of these and change the batteries or get it in their ear is nearly impossible. The most practical, popular hearing aids nowadays are the second ones down, where the electronics are in a small package behind the ear. There's a skinny little tube and some more electronics that just fit into the opening of the ear canal. They sound great, great battery life, or they're rechargeable, they're lightweight, and they come in lots of different colors, so you can get them to match your hair color, or you can make a fashion statement if you want it to be, you know, hot pink. The biggest problem we've had in the last few years with behind the ear is that everybody's got glasses and masks. And if your mask loops over your ear and your hearing aid loops over your ear and your eyeglasses loop over your ear, it's a lot of traffic. And when you take the mask off, the hearing aid shoots across the room and you can't find it. You can think of these many different shapes and sizes and sort of features and options of hearing aids like a car company that has a, you know, a two-seater sports car and a family car and an SUV and a whatever. And that's kind of the way the hearing aids are. And it turns out worldwide, there are about 5 electronics companies that have 80% of the world market for hearing aids. And they all get their chips from one factory in Taiwan. And there is very, very little difference from one company to the next in terms of the technology. And they all make a two-seater sports car and a minivan, and they all have the economy model and leather upholstery and a sunroof. And it's exactly the same with the hearing aids. And really, the biggest difference in hearing aid sales is the human sitting across from you at the desk in the hearing aid center. And if that's somebody who is well-trained and compassionate and patient, you're likely to come out with a more satisfying purchase. In Massachusetts, to be a hearing aid dealer, you need to have a high school diploma and you need to have done a 1-year internship with another hearing aid dealer, and then you can get a hearing aid license. You don't have to be an audiologist, you don't need a bachelor's degree, you don't need a master's degree, you don't need a doctorate, you don't need a high school diploma and a little time in somebody's office learning the tricks of the trade. I think you're more likely to get a satisfying purchase if you see an audiologist who dispenses hearing aids, who has some training in the science of this as well as the, you know, how to fill out the sales receipt. The middle column here where it says prescription hearing aids, that's what we've all had for years. These are the instruments I was showing you in the previous pictures. Typically, they cost around $3,000 to $4,000 each. Most hearing aid vendors give you a deal if you buy a pair. The second one is reduced, so it might be $4,000 for one and $6,000 for two. You know, you get like half off the second one. They're dispensed with a doctor's prescription, or a person can just walk in and buy one, but they sign away their right to a doctor's recommendation, so that you could just go and buy one without the doctor checking you first. I would recommend you see an ENT doctor and have somebody look in your ear and make sure that what the problem is and so forth before you go buy hearing aids. It's a state law in all 50 states in the United States that anyone who wants to sell you a hearing aid has to provide it with a money-back trial for a minimum of 30 days. Many vendors give 45 or 60 days, but that is a state law all over the country. That gives you the chance to get fitted, go home and use it for a month or two, learn how to use it, let the novelty wear off. There is a learning curve to get best use out of the aid or aids. And then you can decide after that trial period whether you want to keep them or not. When most of us see patients who are hearing aid candidates based on their hearing loss, we strongly recommend that they do the hearing aid trial period and then decide if you want the aid. Don't decide without trying. That's making an emotional decision. Nobody wants a hearing aid. But if you try it and then you have actual lived experience of what it can and can't do for you, then decide if you want it. And if not, you get your money back. You're out a service charge, $100 to $200 service charge typically. Now, there are other products that make sound louder. Those are on the far edge. Those are not considered medical devices. And then there's a new thing, which is the column closest to me, that says over-the-counter hearing aids. And a couple of years ago, Congress passed a law that hearing aids could be sold direct to consumer. And that law kicked in last October 2022. It's a federal law all over the United States now. There are medical grade hearing aids that can be sold directly to you, and you can find them online. They're beginning to show up at CVS and Walgreens. You could think of them very much like drugstore reading glasses. You know, if you have a simple problem that you need the text a little bit bigger, you can go drop 20 bucks at the drugstore and get readers. You can, you know, kind of figure out if you need 1+ or 2+ or whatever. So there is now a hearing aid equivalent. They're not 20 bucks. They are, the early ones that are coming out are priced around $200 to $1,000 each. That's only 20% the cost of a prescription hearing aid. Most of these, the better ones, come with a controller app that you put on your phone, allows you to adjust the bass and treble and the loudness and so forth. So they seem like they're going to be pretty good. We know that some big name consumer electronics companies, Apple and Bose and Sony, are making them. And it's a good bet those are going to be very high quality and at the higher end of the pricing schedule. But pretty soon you're going to see these all over the place with electronics names you've never heard of. And they also probably get their chips from the same factory in Taiwan, but we just don't know. Right now it's kind of the Wild West. And I can't make a recommendation to you about which instruments to get and which ones are going to last. For a prescription hearing aid typically lasts about 5 years. And by 5 years, they're beginning to have some static and crackle and not sound as good. You might have more hearing loss by 5 years and need more horsepower. And the technology changes. In 5 years, you know, you wouldn't buy a laptop computer and expect that 5 years down the road, you're still using the same old clunky laptop. And this is, you know, sort of the same logic. We don't know how long the OTC aids are going to last. It may be only 20% the price, but if you have to replace it every year, at the end of 5 years, you spent the same $5,000, you know? We just don't know yet. But For people who have a pretty simple hearing loss, both ears are about the same, they've lost some loudness, but their clarity is still pretty good, over-the-counter hearing aids may be a very good solution. And I think in the next year or two, you're going to see lots and lots and lots of that. If you want to know more about hearing aids, Consumer Reports usually does a hearing aid review every few years. They don't recommend a particular brand so much as talk about how do you shop for hearing aids. And if you get prescription aids, they come with a service contract and a warranty and all kinds of stuff. We don't know yet about the OTC aids. I think most of us in the profession think it's a good thing that this simpler management is coming down the line. One of the things that's missing is that you just buy it off the shelf, and if you need help with it, if you don't understand the instructions or it doesn't feel like it's fitting right, you could come to Mass Eye and Ear and you could buy an appointment with the audiologist and they'll teach you how to use it. Because if you buy a prescription aid, you get all that service kind of baked in. If you buy it over the counter, you got to then add on extra help in some cases. So I have to tell you that there are 3 little secrets about hearing aids that you must know. A good audiologist selling you aids will tell you all these things right up front. Over the counter, you won't necessarily know it. Reading the advertising hype from the manufacturers, you won't know it. Somebody in a strip mall with a hearing aid franchise trying to sell you their top of the line will not necessarily take the time to tell you these 3 things. Number 1, hearing aids are amplifiers. They make sound louder. They do not improve clarity. Way back, I showed you that audiogram where somebody had, their loudness was halfway down the page, but they only had 40% clarity. If you put on a hearing aid, it's going to be loud enough, they'll hear everything, but all they're going to hear is noise. You could liken this to a radio station that doesn't tune in very well. Bad reception, turning up the volume does not give you a satisfying listening experience. And so one of the really important reasons to see a doc and get a comprehensive audiogram before you go hearing aid shopping is if the ear has very low clarity, hearing aid's not going to solve your problem. And we see lots of people who bought a fancy schmancy hearing aid and then they returned it and they bought another one and they returned it and they bought another one and they returned it and then they come and see us and they say, the hearing aid doesn't work. You mean it doesn't work? There's no sound? They say, there's lots of sound, I just can't understand everything. The hearing aid worked fine, but they had unrealistic expectations of what the hearing aid could accomplish. Second thing, the hearing aid doesn't know what you want to listen to. It makes everything loud. So I talked to you earlier about the signal to noise ratio. If the signal to noise ratio is not great, I could go into a quiet room and close the door. I could turn off the dishwasher, turn off the microwave, turn off the radio so I reduce the noise. I could talk louder and boost the signal. I could look at you when I'm talking instead of talking into my newspaper or my menu. If you're hearing impaired, you or your spouse is hearing impaired, and one's in the living room watching TV and the other's in the kitchen chopping vegetables, you are not having a meaningful conversation. You need to see the person who's speaking to you. That boosts the signal. Lower the noise, boost the signal. If you put on a hearing aid, they both go up in tandem. It doesn't separate them. So in a quieter environment where audibility, detecting the sound is the problem, hearing aids are great. Having a conversation at the dinner table, talking to the kid at the checkout counter at the grocery store, sitting with a couple of friends and having a cup of coffee, great. But if you go to a cocktail party or you go to a, noisy restaurant, busy street corner, the hearing aid is really not going to get you where you want to go. And in fact, nothing is, because the electronics don't know what you want to listen to. Now, it could be in the next few years, you'll see some AI gadgets that do this for you. There are people talking about having little cameras on your eyeglasses. You look at the person you're talking to, and the AI reads their lips and plays it loud into your ears. So wherever you look, that's what you hear best. Now that's kind of on the drawing board, but nobody's got that product yet. We'll see if it comes to pass, but maybe. The last secret is that hearing aids only work if you put them in your ears. They don't work in your glove compartment, they don't work in your violin case, they don't work in your dresser drawer. You know, to drop $5,000 or $6,000 or $7,000 on a pair of hearing aids that sit in your desk drawer is tragic. So you have to be open-minded about giving them a try. It's why I encourage patients to do the trial period before they decide whether to keep them or not. Make an informed choice. There are a few other devices that we offer to people with hearing impairment. We call them situational remedies because you don't wear them all the time. You only use them in certain situations. So some of these are assistive listening devices, like an extra loud ringer on your phone or your doorbell or your smoke alarm, or a volume control on your telephone so you can crank it up loud. There's a gadget called TV ears, which is a wireless headset that attaches to the television. It allows other people in the room to hear it at normal loudness, but the wearer of the headphones has their own volume control. And you can crank it up without bothering the neighbors. They have several different models. They're $200-300 generally. You buy them online. Patients like them quite a lot. They only make the TV louder. They don't make anything else in the room louder. So they're helping your signal to noise ratio, but they don't help you at the grocery store or the dinner table, just the television. Now there are similar systems in churches and movie theaters and other auditoriums, performance spaces. The Americans with Disabilities Act mandates by law that all public spaces have to offer assistive listening devices. And so when you go in for free or for a nominal fee, a few bucks, you can get a headset and a little wireless thing. You put it in your pocket and you put on the headphones and adjust the volume. Quite common at churches and synagogues, and quite common in theaters. If you go into Boston to any of the theaters, Huntington Theater and so forth, they have those in the lobby for a small fee. This is a gadget made by a hearing aid company called Phonak. They call it the Roger Pen, and the little square block is the charging station. The cylinder is the pen. It's just about the size of a pen, and it has a microphone in it, and it's got a Bluetooth broadcasting thing, and you have an earpiece that you wear when you want to hear something. And when you're holding that microphone and pointing it at something, it's highly directional. Wherever you point it, that's what you hear. So if you were in an auditorium and pointed up, or a classroom and point at the teacher, the speaker up front, that's what you're going to hear, not the people next to you unwrapping their cough drops. If you put it down on the counter, it becomes omnidirectional, and it picks up everything within a radius of a meter or two. So if you have a business meeting and you're all sitting around the table and you put this on the table, everybody at the table is right in your ear. Now, if they're all talking at once, it's not going to be great, but it does get the sound to you, and you don't wear it all the time. You put it on when you need it. Now, you can do the same thing with your phone. It turns out there are apps you can put on your phone for free or for $2 a night. This costs $1,700. If you're only going to use it for, 20 minutes once a month, it's probably not worth it. If you need it every day, in school or at work, maybe it is worth it. But for $2.99, you can put apps on your phone called personal sound amplifiers that do the same thing. You put your phone down on the counter and the microphone picks up everybody, almost like speakerphone, but it Bluetooths it into your earpiece. You just wear one, an Apple iPod or some other earpiece, so that you can save a lot of money with the do-it-yourself workaround. And this is an example of an app called Live Listen that works with AirPods. And the AirPods are $100 bucks or $200. I don't know what they cost now, but you probably already have the phone and the app is almost free. So there are workarounds for these situational remedies. Having a hearing aid nowadays, like nobody even notices, everybody's got stuff stuck in their ears. So the stigma is not the way it used to be. And there are some people who are so deaf, either because they've lost so much clarity or the threshold is so far gone that hearing aids are not an option. And those patients get a cochlear implant. And you can think of a cochlear implant like a thermonuclear hearing aid. It has two components. One of them is a package of electronics that's implanted surgically. We make a cut behind the ear, we drill a little window in there and put in a bunch of electronics into the inner ear and sew it up. And after it heals, the patient wears this jumbo shrimp type hearing aid with a little antenna that clips on magnetically to the buried portion of the device. The external sound processor collects the sound and it converts it to electric signals. The antenna transmits those to the buried electronics and it actually sends electrical pulses to the auditory nerve. So it takes the place of all the rest of the cochlea, all those hair cells and everything else, and it stimulates the nerve directly. It's been around since late 1970s. And thousands, 100,000 of them have been done worldwide. It's very routine technology now. They cost between $75,000 and $100,000. So you're not going to buy one out of petty cash. You're going to need health insurance for that. But it's not cosmetic. It's something people really need. Historically, we've only done this when both ears are seriously deaf. But in the last few years, insurance companies are beginning to pay for single-sided deafness. You may have one ear that's good and the other ear is deaf, and you could buy one of these. And you go get it operated. The surgery itself is usually day surgery. It takes about 2 hours, home the same day, and you avoid strenuous activity for 10 days and you let it heal for about 4 to 6 weeks before you do the hookup. The sound is different than the other ear. And it takes a while for the brain to kind of get used to this electronic sound. It's just different. 99% of people who get a cochlear implant get sound reception of normal sensitivity. They can hear sounds as soft as you and I. The hooker or catch is the word clarity score. We generally don't ever implant anyone unless their word scores are below 50%. And an average implant user gets a word score around 50 to 60%. So if your word score was 20 and we bring it up to 60, wow, it's fantastic. If your word score is 50 and we bring it to 50, meh. So it's really not worth considering unless the hearing is really quite terrible. It's a surgery, there are complication possibilities and so forth, but it is the standard treatment now from infants born deaf right up to 80 and 90-year-old patients who are too deaf for anything else. They have to be healthy enough to have 2 hours of surgery under general anesthesia. And we do see that the older the patient, especially advanced age, beyond age 80 or mid-70s, the benefit of the implant declines because the brain has to adapt to the new sound. And as we age, our brain plasticity, flexibility of the brain is just not as good. And so we see fabulous results in children, and the older the subject, the less fabulous. And in people of advanced age, it gives them good sound awareness, but rarely good hearing clarity. It may still be better than nothing to try to keep them engaged. I want to recommend this book, Shouting Won't Help. Catherine Bouton, who wrote the book, was an editor at the New Yorker when she started losing hearing. And this is a memoir she wrote quite a few years ago now. It's a great book. She sort of alternates chapters between telling the story of her experience of losing hearing of a certain degree and then something about the science of what was happening and how it was dealt with medically. First, she lost hearing and denied it. Then she lost enough hearing that she got hearing aids. Then her hearing got so bad that she needed cochlear implants, and she got cochlear implants. And so the book takes you through the entire journey. And I think not everybody who loses hearing ends up with cochlear implants, far from it. But it's a wonderful book. It is comforting in some ways to people who are struggling with their own hearing loss, and it is fabulous for the close family members of people with hearing impairment. I just think she does a terrific job describing what it's like to be hearing impaired. And so, you know, for the spouse to get it about what the other half of the couple is going through, or for kids to understand their parents or whatever, it's a terrific book. Questions? Yes?
Has anyone thought about sign language for deaf people? I mean, you know, for people going deaf.
Yeah, so the question was about sign language for people going deaf. The answer is no. And the reason is that there is a segment of the population that is culturally deaf, where sign language is their native language. And kids who are born deaf are typically that group. And everyone they hang with speaks sign language. It's their native language. And everybody in the family makes an effort to learn so they can communicate with their deaf family member. But if you learn sign language now, who are you going to talk to? Unless you become a member of the deaf community, and they're going to be fluent and you're going to be struggling.
I was thinking about teaching the whole family.
Well, you could. It would be equivalent to moving the whole family to Norway and say, okay, everybody, we're going to speak Norwegian now. And they could struggle to do it, but it would be months and years of hard work before you could have an easy conversation with your family. And the reality is that nobody does that. Sign language is for people who are embedded in the deaf, capital D, deaf, you know, culturally deaf community, or wish to work with that community on a regular basis. And, you know, certainly if you want to be bilingual in, you know, in English and ASL, American Sign Language, great. And a lot of colleges have programs that teach it, just like they have programs that teach other languages. And there are signing interpreters or translators, just like there are for French and Russian. But any of us, if we were losing hearing now, signing would not be a helpful way to go forward. Yes?
I have a couple questions. One's like, if you're, let's say you're taking music lessons and you try to get your sense of pitch like more trained, like is that the stereocilia becoming more, do they get better at it?
So,
I mean, like, you know how you can get to the point where you can really discern?
yeah, so that's in your brain, not in your ear.
Can you repeat the question?
Yes, the question was if you are a musician or learning to play an instrument and you're trying to become very aware of subtle changes in pitch, like tuning a violin, is that your ear that's doing that, or is that your brain doing it? So your ear collects all that information, and it has, you know, it can detect a difference of 1 or 2 cents, you know, which is 1/100th of a hertz. But it's your brain that gets sensitive to it, you know, that begins to discern it. And some of us are better at it than others. It is certainly trainable, but if your ear is intact and fully capable of collecting all the sound, you're more likely to be able to develop good pitch discernment. If you have a hearing loss, then, you know, it'd be like learning to read with dark glasses on. You can't really see well enough to do the next task, which is making sense of what you're reading.
So basically, like, people the whole time they're collecting the information, but it's a question of training. So when you take
Your brain has to be able to tell the difference.
okay, and then so when, like, let's say
Talk into the microphone.
okay, so it's on. Is it on?
Yeah. Just
Hello? No?
Yep.
There you go. So then when you train your brain to do that, so like as you okay, so as you get older, you want to protect your hearing, right?
You want to protect it now so that you still have it when you get
You
older.
want to protect it the whole time.
Yeah.
So what would do you recommend just getting the stuff in you know, the store? Or I actually have things which I got from Meniere, but
Yeah,
Is there
so
kind of that, or do you, and then, is there any way, other thing you could recommend for people, like, you know, so that they kind of
so
protect it?
so loud sound can damage ears. We call that acoustic trauma. And what we know about acoustic trauma is that it is a dose effect. That means the bigger the dose, the faster and more damage that you cause. Just like taking a bigger dose of a drug has a bigger effect. So below a certain loudness, the ear has no damage. And generally we think that that cutoff is around 80 or 85 decibels of loudness. And in fact, another thing you can put on your phone is a sound level meter that reads the decibels of sound around you at any time. And those are free. You could go to the App Store and pull down a sound level meter, put it on your phone. And if your average noise exposure, you're in the practice room, rehearsing a piece and your meter is on and you look at the average readout for the hour and it says 80 dB, you could live there, it won't harm your hearing. But as you get up above 85, the louder it is, the more quickly you do damage. You're probably safe for 8 hours at 85 decibels, and for every increase of 3 dB, you have to cut the time in half. 4 hours at 88 dB, 2 hours at 91, 1 hour at 94, and so forth. If you're a violinist and you're playing forte, you're getting 95 decibels in the left ear. And we see that most accomplished violinists have a left ear hearing loss in their high
I
frequencies.
could probably attest to that, but it's maybe because of the drum set that's right.
Well, yeah, the music can get pretty loud.
So
Anyway,
stick with
if
one of
you attenuate the sound, if you lessen the intensity, you increase the safe exposure time.
So if you stick one of those, like, neon colored things in there,
That's better than nothing.
so, but then you lose like kind of that array.
Well, so inexpensive noise plugs, the squishy foam ones that are neon orange or neon, you compress them and you stick them in and they swell up. They're you can get 5 pair for $2 at CVS. You can buy jars of 100 of them. They work, but they do not have a flat frequency response. They don't take down the loudness equally across all pitches. If you buy musicians' earplugs, they do have a flat frequency response. And if they're rated for 10 decibels, they take everything down 10 dB. So it takes forte down to mezzo, but it doesn't distort the bass and the treble. You can still blend with the rest of your quartet. And so musician plugs are what we recommend. And you can get inexpensive ones for 10 or 15 bucks that are not terribly comfortable. You can get more comfortable ones for 40 bucks. Or you can go to Mass Eye and Ear or many hearing aid places and they'll make custom molded ones that are molded to your ear just like a hearing aid is. And they're about 150 bucks.
I mean, I have those, but can you now use an app in those to adjust which frequency you want to hear? And does it matter, like, does a certain frequency do more or less damage to your ear?
Nope, all the frequencies do equal damage, and no, you can't tune them bass and treble.
Anyone else have any questions?
So our 20-year-olds who have headphones in their ears all the time, so you're saying if they're not loud, they'll be fine, it won't?
Correct. The earphones themselves are harmless, and it's the loudness. If you're standing next to somebody and you can hear the music coming out of their earphones, they're killing their ears, killing them. If you're because that earphone is an inch from their eardrum. You're 3-4 feet away. If you're standing in an elevator hearing somebody else's music, they're going deaf. And we now know that by age 20, close to 20% of our kids have hearing loss now. That doesn't mean they're hearing aid ready, but they have done acoustic trauma that we can measure on an audiogram. One of the other things we know about noise injury in the last 10 or 15 years is that it's a gift that keeps on giving. If you damage the ear with loud noise and then you never get any more loud noise, the ear still degenerates faster than somebody who never went to that concert or shot that gun. It's progressive. And so we used to think you only got damage at the concert or, but now we know it's a progressive problem. And so even if you only go to one, loud dance club in some concrete basement in Berlin. You're going to pay for that the rest of your life.
My question is whether one becomes dependent on the hearing aid and whether in some case it tends to hurt your hearing because it's bringing in, as you say, loud noises,
Right.
loud enough so that you can hear them, but it's sort of doing more harm than good.
No, and in fact is not the case. Nobody is damaged by hearing aids. And the notion of being dependent is sort of saying, are you dependent on your eyeglasses? When you wear them, your vision is in focus, and when you take them off, it's not. And once you've had the experience of seeing in focus, you hate to be without it, so yeah, you're dependent on it, but in a good way. It enables you to read or watch television or drive. And so it's the same with hearing aids. Once you realize how much better you do with the aids, you miss them when you're not wearing them. So it's that kind of dependency, but it doesn't make the hearing worse any more than your eyeglasses make your eyes worse. They don't. You just suffer without them.
So there are all kinds of adaptations. There's, by the way, closed caption on the TV, so you don't need the hearing aid. You can just read the text.
Well, you could try that if your vision is okay.
I have a question about the high-tech hearing aids now. They claim and they offer different program settings, such as music, universal. What is the difference and does it actually work during the
So on many stereo systems, like for your home stereo, there's a thing called a graphic equalizer. It's got a bunch of little sliders that it divides up the frequency spectrum into strips, bands, and you can raise the bass or the loudness of each individual one. And that's how we tune hearing aids. There are band pass filters, and if somebody needs a lot of gain from 2 to 6 kilohertz, we amplify that, but we don't want to amplify the low frequencies and blow the top of their head off. So those presets, and those are in more expensive hearing aids, but every company has those. The preset programs it's that. One of them is set with all the gain the same across frequencies. One of them boosts the highs, one boosts the lows, one boosts just the mid-range for voice. And so if you bought an over-the-counter aid, you could do the same thing with the app controller on some of those. And for many people, I don't know, you have a microwave in your kitchen? What do you use it for?
Sometimes eating, sometimes cooking.
Okay, so if you buy a microwave, it'll roast a turkey, it'll bake a pie, it'll do this, it'll do that. It has like 99 settings. And what you do is you put it in and you set it for 30 seconds to heat up your coffee. And so when you buy a hearing aid, to buy a Swiss Army knife of a hearing aid and then just turn it on and off is kind of a waste of money. And when you go to a good hearing aid vendor, they're going to interview you about your listening needs. Do you sit home alone and watch TV? Do you go bowling? Do you go to the symphony? Do you, are you in little groups? Are you in big groups? And then they're going to look at what they have to offer you, the different features and options, and try to do the matchmaking. They have to give you your money back if you're not satisfied in a month or two. So they don't want you to be coming back and wanting your money back. So they're going to try to match you with something that meets your needs.
Thank you very much. This is all excellent information. My question is about earwax. And is there any correlation with nutrition? Can you stop drinking milk? Or, other than getting your ears cleaned all the time?
Back in the 19th century, earwax was a hot topic. Just like, lumps and bumps on people's heads. The science was descriptive science, and there were whole books written about, what color was it and what consistency. Earwax runs from very pale yellow to black, and it runs from runny to hard as a rock and everything in between. And there are often differences by age, differences by ethnic group, or I guess genetic differences, differences by diet, differences by hormone status. Heat and humidity make a difference. Earwax is a wax. It's an oily substance, just like this stuff. And if it's hot and sweaty, it gets to be more runny. But it's not, nobody's got a way to control it. It just is what it is. Earwax is only produced in the outer third of the ear canal. It's there for 3 really important reasons. People who don't make enough earwax are tortured because it moisturizes the skin so it's not all itchy and dry and scaly. If you don't have it, you have eczema in the ear canal. It helps block the ear from particulate debris, dust and dirt and bugs and things that can't get in your ear because of the wax and the little hairs. And the wax itself has a chemical composition that kills bacteria and fungi so that it helps protect the ear from infection. So it's actually there for a good reason. And it's a minority of people where it becomes a problem.
Is the earwax water soluble?
Sort of, semi. It softens with water, but it doesn't necessarily dissolve.
Any more questions?
How do you determine which are the better places to get hearing aids?
So the question was about how do you decide where's a better place to get a hearing aid? So the first thing I'd say is to look AARP or Consumer Reports periodically put out general information. In fact, the NIH, the NIDCD.nih.gov, the Deafness Institute has information about the general topic of purchasing hearing aids, about the things I was showing you tonight, the sizes and shapes and features. So it's good for you to start by being an informed consumer. The second thing is that you're pretty assured of well-educated, well-informed, and skilled dispensing audiologist if you go to an academic site. If you go to somewhere like Mass Eye or Brigham and Women's or UMass or Boston Medical Center, they have hearing aid departments. You may have to pay a lot to park. It may be a pain in the neck to get there, but you're pretty much guaranteed that you're going to get really high quality service. You could buy the same hearing aid at Costco for much less, but you don't really know the qualifications of the kid behind the counter, doesn't come with the service and follow-up. If you're going to buy a hearing aid from a company, from a store, a hearing aid store, and you see them around in every town, if it's been there for a long time, they're probably giving good service. If they're in a strip mall and they just opened up and they're like pushing hard, high pressure sales over the internet or in the shop, trying to get you to buy a fancier one, run away. And then the last thing is that, as I mentioned, there are lots of different brands. There are roughly 400 different models of hearing aid on the market. Most of them come from 5 big vendors, but there are other companies, and every one of those companies makes 8 different models and so forth and so forth. So there's lots of choices. If you go to a franchise, you go to, I won't name any franchises, but you know them. If you go to a franchise, they're going to have their 3 models or their 5 models and want to sell you the top of the line. If you go to somewhere that's more of a brokerage, they're going to carry a range of instruments. We carry, I don't know what we're carrying right now, 12 to 20 different instruments from different companies, and they cover all the range of price points and features and options. But they're not all from just one company. We have a couple from this and some others from that. We pick and choose the ones that we like, or our audiology department, our hearing aid center, picks the ones they like because of the service contract and the reliability and the customer service that they get from the company and on and on. So there's not a simple answer. I think that probably if you're going to drop that much money, your best bet is to go to somewhere like at a big hospital or medical center. Your next best bet is to go to a brokerage that carries a bunch of different brands. Your next best bet is if you're going to go to a franchise or a private dealer, that it's somebody who's been there for a long time. Ask your friends if they have somebody they go to and they like him, her, they like the place and they feel like they get good service. That's good. It's kind of like asking, where should you buy your car? How good is the service department, Yes, you want to wrangle the best price you can, but you're going to live with it for years, You need ongoing care and feeding, so you want to get a place that you like to work with.
We have time for one last question.
When do you recommend it to go to check your ear, and do you wait until your wife complains?
Certainly, new onset of hearing loss, sudden change in hearing that's going down on only one side compared to the other, hearing asymmetry, those are red flag situations. Sudden hearing loss is an emergency. It should be checked within 24 hours by an ENT doctor because there's only a few days where it's potentially treatable if it was caused by a virus or poor circulation or some other thing. If it's a gradual hearing loss, if it's asymmetric, if one ear is dropping but not the other, that's a red flag because it could be a tumor, it could be a neurologic disease, it could be, some other degenerative process that might need other treatment. If you're talking about just, sort of gradually over the years, you're struggling a little more in the restaurant or your spouse is complaining, anytime. And if you're just curious, anytime, it's a baseline test. It's not so different than asking when you get your eyes checked. You can wait, you're reading like this, and then you're reading like this, and then you're reading like this, and after a while your arms are too short and you just have to go to the eye doctor. And you can do that with your ears, you can put up with it and put up with it, and your family can put up with it. If you're noticing your own hearing loss now, your family's known about it for years. Everybody else notices before you do, because they ask one question and you answer a different one. They talk to you and you ignore them. They tell a joke and you don't laugh. And in our culture, we notice people's age. And if somebody with gray hair or somebody with no hair is out of it in the conversation, they confuse what you're telling them, they misunderstand things, they don't laugh at the joke, they just seem a little out to lunch, we immediately assume that they're having cognitive decline, when in fact they may be perfectly intact and didn't hear you. And so there's a cosmetic aspect of hearing loss. And many patients don't think of it. They think about everybody can see my hearing aid. I have 90-year-old patients who come in, they don't want to wear a hearing aid because they don't want anybody to notice they're old. They're 90 years old. They come in with a walker and they don't want somebody to see their hearing aid. Anyway, people are funny, but I try to remind them that there is this cosmetic aspect of the hearing loss where you misunderstand or you don't, you're seeming to be out of it and everybody assumes that you're losing it. Nobody wants that. Nobody wants to be mistaken for declining cognition.
Thank you. So before we close today, I just want to mention that the book Dr. Rauch mentioned, Shouting Won't Help, is available on the library network, so you can just go to the catalog and request it. We have a sign-up sheet in the back of the room. Dr. Rauch has a couple of handouts that I will email to you, but if you would like to receive it, just put your name and your email address on the sheets in the back of the room. And with that, I just want to thank you, Dr. Rauch, for coming today for such a wonderful presentation, so informative. If anyone has questions and wants to kind of chat with Dr. Rauch, he'll be here for a few minutes after. Thank you so much for coming.
Thank you, everybody.